Hello and welcome to Addis Dialogue. I'm Yodit Admasu. It has been 25 years since Ethiopian People's Revolutionary Democratic Front, EPRDF, overthrew the military junta Derg. The government then set the first try to bring the country out of poverty and make a middle income. Various strategies and plans have been designed at national level to pave the way and transform the country's economy from agrarian to industrial. Over the past years, numerous achievements have been registered in various sectors. The health sector is one of the areas that saw a remarkable success. It has made the progress with the motto, envisioning Ethiopia's path to universal health care through strengthening of primary health care. To discuss on the journey of the Ethiopian health sector, I have invited guests from Ministry of Health, Dr. Taye Tolera, and from World Health Organization, Dr. Olusegun Babanie. Thank you all for coming. First, let's start by looking at the past of the Ethiopian health sector. What was it before GTP1? How was the health system in Ethiopia? And how did it progress afterwards during the growth and transformation plan of the first growth and transformation plan? Can you start by Dr. Taye?
Yes. You know, our health system, Ethiopian health system, is actually built on the health extension program, which is a novel and also homegrown program, and that was that was launched in 2003. And while that was actually registering some results, we also we crafted growth and transformation plan 1, and during that time, if I can say, if I can state some of the health health indicators, for instance, institutional delivery, which is deliveries attended by skilled personnel, was only 16% or 16.5%. And after 5 years of implementing the growth and transformation plan, it reached 60%. In fact, it's even more than 60%, and now it's going it's going up, and it's more than 70%. When we look at immunization, fully immunized children, the percentage was 72%. But after the end of the GTP1, it reached 86%, and the measles immunization rate reached 90%. If we take maternal mortality and child mortality, there was substantial reduction of maternal mortality. It was 676 per 100,000 live births before we started GTP1. But now the estimate shows it's about 353 per 100,000 live births. Of course, we are currently conducting health survey, and we will finally find, the actual figure also.
Okay, so all these developments have also been registered in other areas as well to achieve the Millennium Development Goal, like the malaria and other communicable diseases as well. So, Dr. Babanie, you were here at the time during the launching of GTP1 when the Ethiopian Growth and Transformation Plan was put in place. How was your partnership with the Ethiopian government, and what kind of things did you observe at the beginning?
Well, the first thing I wanted to put on was to add to what he has said about the health. Essentially, there were, in the early 90s, before 2003, there were severe shortages of health manpower and maldistribution. Most of the available health manpower were in urban areas. So government thought of a very unique way of reaching the rural areas with primary health care, and that is why the health extension program came on board in 2003. It is unique. It was the only one started in Ethiopia, after which many other countries have copied. It's a way of scaling up human resource, reaching the rural areas which were sometimes neglected, and making sure that the families are empowered to receive health. And this is crucial, and it's important that we stress this. And in the process of scaling up the health extension workers to get up to the 38,000, there were also building of new health posts, building of new health centers, building of hospitals, and training of more health manpowers, including doctors. And in between the 2003 and by 2013, there has been significant improvements in the quantities. In fact, for nurses, Ethiopia has reached the WHO standard of 1 per 5,000. So we need to express this properly as WHO and give credit to government. For us, it means a government that is championing the maternal and child health of her people, that have mobilized partners, mobilized resources, and put eye on the ball by scaling up training, scaling up skills, and making sure that constantly the process is being evaluated. So this is something that should be commended.
When you talk about the skill and capacity building, you have a program, the Ministry of Health has a program to develop the skills of the health extension workers, right?
Yes.
From time to time they go into training. Could you tell us a little bit about that? What kinds of trainings do they get, and at the end, what level are they expected to reach?
That's a very good question, actually. Well, the health extension workers are all female, and they are trained on basic training for 1 year, and then they start providing this package of interventions, like package of 16 programs. And then every year they also get refresher training, and they are mainly trained on some advances in healthcare, and also some of the existing health programs as well. Right now we are actually undergoing level 4 training, whereby the health extension workers actually advance their career also to diploma level. At the same time, the service they provide to the community is far advanced than before.
The experience that Ethiopia has, the achievements through the health extension workers, you said they are the champions. What is the World Health Organization doing to disseminate this experience to other developing countries that need this kind of health system?
What we have done, at least from the country office level, is to share the Ethiopian experience in our website, which is hosted in the regional office and in Geneva. And through that, many countries approach their representatives in their country to liaise with the Ministry of Health to see how they can benefit from the Ethiopian experience. When I was the Zambian WHO representative, I sponsored a team of 5 here, and they took them around for 5 days, and they came back, and Zambia has copied a modified edition of this, and they call it Community Health Assistant Agents, and they are posted in rural areas and do something similar. It's not up to 16 modules, they have 10 modules, which they some were combined. And this is helping Zambia now. The Ethiopian experience was excellent for them. They post them in health posts which they constructed there, and the rest, as they say, is excellent. And really, and I know some other countries that have come here from Namibia, from Swaziland, and from Uganda. I am sure some other countries have contacted the Minister of Health on bilateral basis without our country offices knowing, but all the countries that care to come here have had very good reports and have all modified experience of Ethiopia to serve their people. So this is excellent.
Can we talk about the primary health care, that's universal access to everyone getting basic health facilities that the government is undertaking? It might be, it is for sure really expensive to do that, but how do you explain that?
As you know, the government of Ethiopia is implementing proper policies in general to improve the daily lives of its citizens. So, guided by this broad government agenda, the Ministry of Health also crafted this proper all-inclusive health policy, which is focused on prevention and health promotion. And it's also focused on primary health care, health extension program, and also health extension workers. Recently, this has been beefed up with health development army. Also, the health extension workers they are getting a very good support from health extension health development army. So it's not really expensive because it's implemented through a partnership between the government, the community, and also our key stakeholders like WHO. It's proper and it's implemented in partnership. So this takes us to actually some programs, high impact interventions being given free of charge. By the way, every service at Health Post is free of charge. And other programs at any level like tuberculosis, HIV, malaria, and maternal and child health programs are delivered free of charge. What we are now doing is actually to ensure financial protection so that the community have their own health insurance, both the citizens engaged in informal sector through community-based health insurance, but also employees of formal sector through social health insurance. And we really think that these two schemes actually propel Ethiopia to universal health coverage in medium term. So that's how this policy works.
Yeah, it's on the way. Yeah. So, Dr. Bamani, when we look at this universal health care that Ethiopia is implementing, even some of the more advanced countries, more developed countries, they are ignoring this kind of service, saying, that's not for us, we can't afford to do that. But Ethiopia, a developing country, is undertaking this free health service for its citizens. How do you see that?
For a country that has more than 50 million people, which in our region we say big four, is Nigeria, Ethiopia, DR Congo, and Angola. Only Ethiopia achieved MDG 4 and also made significant progress with MDG 5. I'm sure by the time they do the last DHS, maybe they have achieved it. We don't know yet, but they are very close. So this is very important. And it's a surprise to many because you will expect a rich country to be able to do it. So moving on maternal, neonatal, and child health issue is not a question of money alone. It's a question of commitment, political will, empowering the communities, getting down and translating whatever you concept at the national level, getting down to the Kebele, which is the district level, making sure you are monitoring, keeping your eye on the goal. That's what Ethiopia did, and that's why they were able to achieve it. It's not just money.
So it's a commitment.
Yeah.
From the government, from the people. So a lot of responsibility for Ministry of Health to continue this success. Coming up as Growth and Transformation 2 period, and also at international level there is a goal set, sustainable development goal set as well. So in achieving that, what are your plans towards that goal? What can we expect from Ministry of Health?
Well, Ministry of Health is actually working to maintain the current trajectory. We are actually succeeding in improving the health of the society. Of course, the goals set in the sustainable development goals are ambitious and bold, and we are also taking bold steps actually. For instance, for health extension program, we are transitioning the first generation health extension program to second generation, whereby we also include non-communicable diseases, mental health, some emerging infectious diseases, and so on. At the same time, time, we're working on transforming Waradas districts, actually, in terms of the performance of primary health care units, health posts and health centers, and also financial protection that has been a challenge for a while. Now we are scaling up community-based health insurance for citizens engaged in informal sectors, like our farmers, our pastoralists. And also we are planning to create model qabalis, model village at national level. The performance of Ethiopia is very, very good, but there are some areas that are lagging behind. And also ensure quality in healthcare. So we are focusing on sustainable, of course, on GTP too, but also maintaining the trajectory so that we actually in the long term reach global commitment, which is SDGs as well.
Okay. When we talk about the global commitments, the Sustainable Development Goals that is set internationally, it's not necessarily about health. It has widened its scope to include environmental, social, various aspects. So in this regard, what is your organization's plan to work with the Ethiopian government in the GTP2 and also in meeting the Sustainable Development Goal in 2030?
WHO we have been working with the Ministry of Health since 1964. And we come here strictly to support the government on her plans. We don't have a separate plan. We work on the same page. We provide essentially mainly technical support, but occasionally financial support. And we make sure that we work on the guidelines, make sure we enhance the training through the ministry. Now, I wanted to add something which we may be missing, and it's important that we say it. There are some non-health factors which has contributed to the MDGs 4 particularly and MDG 5. And for a big country like Ethiopia, it's good we mention them. A few of them is, one, a lot of new roads have been developed and opened up the country. There has been substantive growth of Ethiopia. It's about double-digit growth for the last 10 years. And anybody who is passing through Addis or any of the big towns, you can feel that there has been growth. This filters down to the family and it also improves their socioeconomic status. Education has improved. All these are not in the Ministry of Health, but they do contribute to lowering disease, making the women to have informed choice. Nutritional programs which have improved the nutritional status of children. Empowering the family and the women to be able to make informed decisions to seek health and to collaborate with the health extension workers and the health teams that have been posted in their environment. These are important because if they're not there, it's going to make the things most difficult. Government has mobilized a lot of resources. Apart from our own resources, have mobilized a lot of resources from partners through the coordinating mechanisms that are there. IHP, there's International Health Partnership, there's a compact for which all of us signed. We are working on the government on the same program, the same page, the same report. And all of us agree to fund the Ethiopian program because we believe in it and we can see the outcome. And they are very transparent and they share the results with us because we have annual review meetings, we have midterm review meetings, and at the end of every 5 years, we also independently evaluate this program. So these have contributed in ways to improving and enhancing the ability of the Ministry of Health to achieve a said objective.
So we can generally say that every sector is interrelated.
Yeah.
So if we are thinking about going to middle-income country, we have to look at every sector, not only health, but education, gender, all these sectors are interrelated. And the Ministry of Health is focusing on primary health care, that's more on preventive, right? So we wish you all the luck. That's all the time we have for today. So thank you, Dr. Babaniye and Dr. Taye Tolera, for your time. Well, dear viewers, that's all the time that we have for this edition of Addis Dialogue. I'm sure you have got some hints on the health programs that's going on in collaboration with the World Health Organization. Thank you for staying with us, and goodbye.